Yes, yes. Good afternoon. At the outset, I would like to thank Dr. Satyan sir and Dr. Prasanna Venkatesh for giving me this opportunity. My topic is SLT versus ALT, reigning monarchs of open angle glaucoma. The agenda of the talk is to talk about laser trabeculoplasty, especially on selective laser trabeculoplasty, which is currently used, and argon laser trabeculoplasty, which is seldom used now, and a comparison between the two. Laser trabeculoplasty involves delivery of laser to the trabecular meshwork, which results in either mechanical or biochemical changes at trabecular meshwork, resulting in improved outflow, resulting in reduced IOP. It is primarily used in cases where maximum medical therapy cannot control intraocular pressures to target level, or the glaucoma is not that advanced. It's primarily used in patients who are non-compliant with the medication or have inability to apply medication, either because of aging, poor vision, or tremors, and also to decrease the load of topical medications which are used. There are two theories behind laser trabeculoplasty. One is a mechanical theory, which shows that there is shrinkage of collagen material in the trabecular meshwork, resulting in constriction of the pores, opening up of pores because of constriction of trabecular meshwork, and improved outflow. The biochemical theory states that there is inflammatory expression of interleukins and TNF alpha, resulting in activation of macrophages, which clearing up of debris at the trabecular meshwork pores and improved outflow. There are two types of laser trabeculoplasties. One is selective and another is argon laser trabeculoplasty. The selective laser trabeculoplasty has a principle of selective photothermolysis, which relies on selective absorption of short laser pulse. It is primarily indicated in all open angle glaucomas, and then previously failed argon laser trabeculoplasty, PXF and pigmentary glaucomas, and potential use in steroid-induced glaucomas also been tried. NdArg laser of 532 nanometer, frequency doubled, Q switched laser, spot size is 400 microns. This duration is 3 nanoseconds. The energy used is very minimal, that is 0.4 to 1.2 millijoules. It is applied either 180 degree or 360 degrees of the trabecular meshwork. Move faster, move, sir. Yes, so slides are moving faster. Yes, sir. Yes, sir. It is moving 2-3 slides ahead. When I press one, it goes to 2 slides. This is better. Okay. Okay, thank you. So the energy level when we start the procedure is kept at lowest at 0.8 millijoules, and a test pulse is delivered to the trabecular meshwork. The surgeon is able to visualize a bubble formation. The pulse energy is gradually decreased by 0.1 millijoules at intervals until a minimal bubble formation is detected, and a suitable pulse energy is then determined, and the treatment proceeds. The recommended protocol are always in a flux, and it is started at 180 degrees inferiorly at 50 spots, 25 spots per quadrant, and in severe cases we can try 360 degrees with 100 spots evenly spaced over the trabecular meshwork. The pressure lowering effect is improved if all the 360 degree of trabecular meshwork is treated. There is an alteration in SLT protocol in case of pigmentary glaucomas. It is considered an exception in treatment with laser trabeculoplasty. The SLT energy is absorbed more in pigmentary glaucomas, which results in dispersion into the AC, and intraocular pressure spikes are noticed. So, in case of pigmentary glaucomas, only 90 degrees are treated at a sitting with minimal energy with no bubble formation. Outcomes include 2/3 of the patients will achieve a reasonable intraocular pressure fall within 6 months. Ocular hypertension and early glaucoma have shown 80% drop in medication-free period, and also the target pressure is maintained for up to 3 years. The effects are generally wane over time. Treatment can be repeated with a successful outcome. Even if the initial treatment is failure, we can still continue a second treatment. The common adverse effects include mild inflammatory and mild discomfort for the patient. There is primary anti-synicate peripheral anti-synicate formation and intraocular pressure elevation has been noted, but usually the IOP spikes are very mild. Substantial rises have been reported in heavily pigmented pigmentary glaucomas, which are over-treated with extensive energy. In extensive treated areas, the damage to corneal endothelial cells has also been reported with endothelial decompensation. Reactivation of herpes simplex keratitis and a few cases of macular edema has also been reported. The primary contraindications include the cases where there is hazy media and poor visualization of trabecular meshwork and closure of iridocorneal angle and corneal edema, and inflammatory glaucomas like uveitic glaucoma and juvenile glaucoma. Patients with age less than 35 years are not considered for this treatment. Argon laser trabeculoplasty. It also uses laser burns to achieve intraocular pressure reduction compatible to SLT. The primary indications are very similar to SLT, which are primary and secondary open angle glaucomas, ocular hypertension, and failure to adherence to medical regimen, adjunct to avoid polypharmacy. The mechanisms overlap with SLT with both mechanical and biochemical changes resulting in improved outflow. But in case of ALT, there is more thermal damage to the trabecular meshwork, hence the repeat treatments are generally avoided. In ALT, we use argon laser of 488 to 540 nanometers. Spot size is larger compared to SLT, which is 50 microns. The duration is also longer, 0.1 second. And the energy used is also more, 30 to 90 millijoules of energy. And at a sitting, we only treat 180 degrees. The procedure of ALT, wherein we aim the beam at junction between pigment and non-pigment epithelium. Optimal reaction is a slight blanching. So procedure is, we give 50 burns regularly spaced 180 degrees, 25 shots per quadrant. Post laser, the patient is started on fluoromethalone or prednisolone eye drops 4 times a day for a week. Medical glaucoma therapy is generally continued till we achieve the intraocular pressures at the desired level. The follow-up is dependent on the perceived level of risk. Complications are very similar to SLT, but slightly more because of the increased thermal damage. Peripheral anti-synicase has been noted, acute elevation of intraocular pressures, cystoid macular edema, and anterior-uveitis because of inflammatory thermal damage. Efficacy is very similar to SLT. There is 30% reduction in average intraocular pressure in primary open-angle glaucomas. 50% of the eyes remain well controlled up to 5 years of treatment. Significant scarring has resulted in reuse of ALT has never been tried. Laser parameters, comparison between ALT and SLT. The spot size is larger in case of SLT, and in ALT it is smaller of 50 microns. Number of spots are same, 25 spots per quadrant, equally spaced. And energy used is 500 milliwatt in argon laser trabeculoplasty, whereas it's less than 1% of ALT in SLT. Exposure time is also very minimal in SLT, and there is no thermal damage in SLT. This is a comparison of spot size between SLT and ALT, where you can see the largest spots in SLT of 400 microns. In case of ALT, it is 50 microns. And this shows the thermal damage resulting in coagulative damage of the absorption of thermal energy at the trabecular meshwork noticed in ALT, where in SLT, the trabecular meshwork architecture is maintained. The intraocular pressure efficacy of both the lasers are comparable, but the advantage of SLT, it is repeatable. Rate of complication is also slightly lower in case of SLT compared to ALT. Prognosis, either form of laser trabeculoplasty, actually the effect wanes over time, but both are equally effective. But in case of ALT, since there is no repeat treatment possible, SLT is advised. Advantage of SLT over ALT is it causes lesser damage to the trabecular meshwork, fewer adverse effects. And IOP lowering effects are very similar to ALT, but in SLT it's slightly longer. Repeatability is possible in SLT, but it is not possible in ALT. So, though laser trabeculoplasty is a drying treatment form, there are several advantages attached to laser trabeculoplasty. This reinforces the need to bring in a larger scale implementation usage of this excellent therapeutic option as efficacious alternative. Thank you.
Thank you, Vijay. I accept your last but one slide. We are quite optimistic about our SLT treatment. We all still do the SLT. It is not that SLT is not effective. SLT is quite effective, provided that you understand the angle anatomy properly. Quite a good number of them, they did say that the SLT doesn't work. The simple reason is when you do the SLT on the pigmented Swalb's line, it will not work. When you really do the SLT on the trabecular meshwork, the pigmented trabecular meshwork, it does work. The confusion for many of them is the angle anatomy. If you really can't understand the angle anatomy, then the SLT doesn't work. In primary open angle glaucoma, when the eye is a virgin eye, then the SLT really works. And there are controversies on what is the power settings. The power settings say, for example, you have the bubble formation, then you reduce 0.1, which doesn't work. When you have the bubble formation, it is better you keep seeing the bubble formation throughout rather than just reducing it. Once the moment you reduce it, in our hands it doesn't work when you reduce the power from that level. So for some reason, the imported SLT machines which I have is not that effective in comparison to the local machines. Like I don't know whether I can name the brand. Appasamy machine works much better for me in the SLT. We have the SLT and the ALT in the same machine, not ALT, SLT and the AIOC
Yeah.
So that machine really works perfectly as long as you can do it on the trabecular meshwork with a good power settings. So it is not that we have just written off that SLT doesn't work. It still works. It has a role to play, especially when you want to add second or third medication. It really has a role to play. So we'll have the more discussions after